Everybody, thank you so much for joining us today. So for today's Grand Rounds, I am thrilled to present our speaker. So Steve Hodi from the Dana-Farber Cancer Institute runs the melanoma program, and he also runs the immuno-oncology program up at the Farber. He's a professor of medicine and has an endowed chair. He's the Sharon Crowley Martin Chair in melanoma. I've known Steve for many years. He's been on the faculty at Dana-Farber since 1995 after finishing his medical school at Cornell and his graduate education between the University of Pennsylvania and the Farber. Steve has made major contributions to the melanoma field. He's lead author or first author on multiple publications in major journals such as the New England Journal of Medicine, Lancet Oncology, and the like. He's made some seminal breakthroughs in clinical care as well as in preclinical research. He's pioneered two approaches that I recall that have really changed the landscape of what we're studying and doing in melanoma. One is combination of angiogenic therapies and immunotherapy, and the other one is combinations of GM-CSF with immunotherapy. And I believe he'll be talking at least about the latter. He has a few other very novel gene therapy approaches that he's using, which I think he will be talking to us about as well. So we actually originally wanted Steve to come down last June. Marcus and I invited him as part of the skin SPORE administrative core, but unfortunately wasn't able to come last June. We're glad to have him here today, and we look forward to seeing him in person sometime in the near future. So without further ado, I'd like Steve to take the screen over and take it away. And if you have any questions for Steve, please put them in the chat box.
Well, thank you very much, Harriet, for the very, very kind introduction. And I do hope that we get to see everybody very soon. Let me just get, and if you can verify, you can see slides and everything, okay?
Yes, we're seeing it well.
Great, thanks. And I do hope we can all see each other again soon. Everyone is doing well. So it's a pleasure to join you all today. And I'm going to be kind of talking a little bit of leading up to some ways to think about rational combinations of combining with checkpoint blockade. So as a clinical investigator, I think of cancer therapeutics and such that cancer in people are present for a long time. So there's an opportunity for antigen recognition that may be slightly different than what we see in the transplantable tumor models, the transplantable tumor models being key to understanding mechanisms. But we've also found more recently that the translation into people may be challenging. Some of the aspects related to agonist targets and other things in terms of the right pharmacology is also fairly challenging. So in the world, in the PD-1 world that we're living in the checkpoint world that we're living in, why do anti-tumor immune responses do not happen in order to clear cancer? So they've either never developed, the immune cells are too few in number, or they're exhausted. And this, obviously, the exhaustion is very important in the PD-1 world we're living in. They could physically be excluded from the tumor, or the antigen-presenting machinery is somehow disrupted with antigen loss, or the antigen machinery itself, such as MHC loss, which we're going to try to address most of these over the next hour or so. So in the beginning, there was ipilimumab, anti-CTLA-4, and just to use melanoma as the paradigm example, traditionally melanoma would have about 11 months median survival. For brain mets, 6 months or less. And now we have with IPI, the 22% of patients now having long-term survival with over 10 years of follow-up. And notice on the survival curves that there's an inflection point around the 2.5 to 3 year point, and then the flattening of the curve, which we also interestingly see with nivolumab anti-PD-1. This is the kind of combined data, a little bit of mixing apples and oranges in terms of dose and schedule, all previously treated patients. Then now those patients, about 35% are living long-term with nivolumab monotherapy. And then moving on to the most recent update of the Checkmate 067 trial in melanoma, which was a phase 3 trial that combined Nivo plus Ipi and compared it to Ipi alone and Nivo plus Ipi compared to Nivo. It was not designed, the caveat here, not designed to compare Nivo Ipi to Nivo. But now with 6.5 years of follow-up, you again see this inflection point around 2.5 to 3 years, flattening of the curves with Nivo plus Ipi now 56%, 57% or so of patients living long-term with the disease. So the question is, with this kind of as the new baseline, how can we improve upon these results? And we look at very important biomarker data. So the importance of CD8 and the invasive margin. So it's the tumor stromal interface and the proximity, the closeness to the PD-1, PD-1 interaction is highly predictive of responses to anti-PD-1 therapy, again, in melanoma. And also that PD-L1 is a biomarker. And now with the numerous diseases that PD-L1 is looked at, PD-1 target therapies, that actually PD-L1 expression on immune infiltrating cells. So the immune cells themselves, mostly macrophages, are also predictive responses to here anti-PD-L1 atezolizumab in patients with lung cancer and now other cancers such as kidney cancer. So to briefly summarize other aspects that could be applied to improving upon those results, quite a few years ago now, Glenn Dranoff, my long-term mentor and friend, and I did some anti-CTLA-4 antibody trials looking specifically in patients who had received a prior GM-CSF-based vaccine, but noticed pathologically when they received ipilimumab that there was this in panel A, area sentinel necrosis with a rim of viable tumor around the outside, and that rim of viable tumor was heavily infiltrated with CD4, CD8, CD20s. But we noticed throughout the tumor that there was an immune attack of the vessels feeding the tumor deposits depicted in panel F, and that these lymphocytes were attacking the blood vessels with necrotic debris in the center and probably leading to this TNF-like effect that we visualized in pathology. And so it raised the question of the combination, as Harry was alluding to, of combining anti-angiogenesis and immune checkpoint, and the importance of hypoxia, HIF-1 alpha, making VEGF, that not only involved angiogenesis, but VEGF being a very potent suppression of dendritic cell maturation. And that other important suppressor cells in the tumor microenvironment, like myeloid-derived suppressor cells, also make important angiogenic factors such as VEGF that lead to also this suppressive feature. And whether there was a role for angiogenesis in terms of not just being blocked for blood vessel formation, but also its role in immune activation and in immune suppression. So we looked into this further, summarizing some work from a few years ago of combining CTLA-4 blockade with anti-angiogenesis based on the vasculopathy that we saw pathologically, the role of VEGF in decreasing dendritic cell maturation. Work by George Kukos and others, Rakesh Jain at Mass General, also had shown that blocking VEGF improved T cell trafficking across endothelia. And we worked with Jed Walchuk and Memorial looking at pretreatment levels of VEGF, which were associated, the higher the levels, with poor outcomes, both less responses and less survival. Again, guilt by association that VEGF may play a role with immune checkpoint blockade. So this is just kind of some summary of that. Here's a PET scan of a patient. On the top, the CAT scan portion shows us liver metastasis, and then that is lit up by PET. And after just a few months of treatment, the liver metastasis hasn't changed in size, but has become metabolically cold. And this trial with IPI alone had a response rate of about 35%, and 50% of patients doing well with control of the disease for 6 months or more. So this is a background. I think the correlatives give you the basis for this combination, in that we look at the pre and on treatment on the left and comparing to patients who received IPI alone on treatment on the right and some control samples. And the patients who received bevacizumab, anti-VEGF, had changes in the endothelium as depicted by CD31, where they morphologically looked plumper, columnar, and biochemically were activated with upregulation of E-selectin. These morphologic and biochemical changes in the endothelium were associated with kind of a robust and brisk lymphocyte infiltrated on the larger insets here. You can see that some red cells in the center of the endothelium and lymphocytes completely surrounding it, in comparison to what we see with IPI alone, which was really very little changes in the endothelium. In addition, the endothelium with VEGF blockade with bevacizumab had upregulation of other important anchoring molecules such as VCAM and ICAM that you can see highlighted in the endothelium here, that also suggests that by blocking VEGF, you can potentially improve the trafficking of lymphocytes into the tumor microenvironment, and thus approaching one of the concerns we had at the beginning of the talk, which was whether the lymphocytes, the immune cells, can actually make it in the tumor microenvironment or if they were excluded. So based on this, Janacek went on to do some bevacizumab trials, and they did something very smart. They gave a single dose of bevacizumab before combining with checkpoint and did biopsies before and after bev, and fortunately showed that the BEV, the VEGF-A blockade by itself, had changes in the endothelium and had improved lymphocyte traffic and cross CL1, and also the fact that the RNA-seq in the tumors that had a myeloid signature seemed to do better when they received bevacizumab. Again, tying in that myeloid suppressor function, the VEGF function, with the suppressive aspect of the immune system, and that those patients who had those myeloid cells there and received Bev had a marked improvement in their outcome. So this concept has very rapidly progressed, and obviously in important diseases such as kidney cancer that is driven by HIF-1 alpha and angiogenesis. Here's anti-PD-L1 avelumab plus axitinib, VEGF-R123 inhibitor TKI, showing that combination had improvement over sunitinib alone. And other data, pembrolizumab plus axitinib, so anti-PD-1 plus VEGF-R123 inhibition versus sunitinib having improvement in both progression-free and overall survival. And this kind of concept has expanded very quickly to non-small cell lung cancer with some data showing improvement with angiogenesis combinations, and either will or has probably checkpoint plus anti-angiogenesis approvals in hepatocellular carcinoma, endometrial carcinoma, and with other many combinations being developed. So one of the questions we had is, what is the role of the immune system in this anti-angiogenesis in terms of the role of angiogenesis and its direct effect on immunity? And so in some of our patients, we have a banking aspect. We collect from their biopsies, try to isolate myeloma cells. We also collect tumor-associated endothelial cells and also tumor-associated mesenchymal stem cells. In a very simple experiment, Western blot or immune blotting here, looked at before and after treatment with anti-angiogenesis checkpoint combinations, and found that patients post-treatment from their humoral immunity had either recognized new antigen targets or had higher antibody titers to certain antigen targets. And just of note, the bottom left-hand corner is that these tumor endothelial cells do make tube formation, so they are functional in that. And so we were interested in trying to isolate what those targets are, because they were seen, some were seen in myeloma cells, some were seen actually on the endothelial cells themselves, as well as other mesenchymal elements as mesenchymal stem cells within the tumor microenvironment. So one of the factors that were found in doing our kind of a CDNA expression library screening of endothelial cells was this other angiogenic factor, angiopoietin-2. And so it kind of shows that patients can at least make antibodies against another angiogenic factor here, Ang2. And Ang2 is involved with angiogenesis through sprouting and endothelial cell migration. It's involved with actually anchoring the endothelium to pericytes and kind of the scaffold of the endothelium for them to gain structure. And it's also been shown to be involved with resistance to bevacizumab. So in many trials, mostly with chemotherapy, those patients who developed resistance all had higher levels of angiopoietin-2 as a kind of a resistant tie. Now, to tie in the angiogenesis back with the potential for immune regulation, angiopoietin-2 not only signals via the Tie2 receptor found on endothelium, but also Tie2 receptor, which can be found on tumor infiltrating monocytes and macrophages. So again, the myeloid component here being tied in, as well as the link between angiogenesis and macrophage biology and immune suppression. So there could be a dual role for angiopoietin-2, both in terms of the angiogenic component as well as immune regulation. So we were further interested in just kind of taking a look at this and found for a number of combinations that angiopoietin-2 levels were associated with outcomes to treatment. So patients who had higher levels of angiopoietin-2 or changes in angiopoietin-2 levels did worse, and that patients who developed antibodies to angiopoietin-2 did better, as showing both for patients with IPI on the bottom here and for patients who received IPI plus bevacizumab. On the top right-hand corner, which is the ratio of antibodies to Ang2 afterwards to pre levels, there are a couple of patients who had high titer antibodies and who had their angiopoietin-2 go up, but they had the highest angiopoietin-2 antibodies that were present. So one of the questions is whether the humoral immunity being developed is actually functional. And we have some data that the patients who are making antibodies to angiopoietin-2 some of those antibodies can actually block Tie2 signaling both on endothelium and in macrophages. So the immune system may be very smart in terms of actually making functional antibodies against an angiogenic factor here, such as angiopoietin-2. So here's some of the data showing that as a function of treatment, patients get higher levels of angiopoietin-2 antibodies, both with patients who receive IPI, combination IPI-Bev. We have data showing anti-PD-1 patients also develop antibodies to angiopoietin-2 as a function of treatment. So one of the questions, again, maybe a guilt by association, is the expression of angiopoietin-2, which seems to be suppressed by VEGF blockade at times, associated with these myeloid cells in the tumor microenvironment. Now, in preclinical animal models, people define M1 macrophages as more tumoricidal, M2 is more suppressive. In humans, it's a bit more challenging to define M1 versus M2, and it's really more functional characteristics. But here we wanted to look at patients who received IPI alone, IPI-Bev, so we had these samples to look at angiopoietin-2 expression before and after treatment. And what we found is that with bevacizumab, if you look both in the tumor and in the endothelium, that you get decrease in angiopoietin-2 expression as a function of VEGF blockade. But with IPI alone, angiopoietin-2 seems to increase in both the tumor cells and in the endothelium. We then correlated the level of angiopoietin-2 that we could find in the endothelium to CD163 cells in the tumor microenvironment. CD163 can be a marker for myeloid suppressor cells or dendritic cells. And what we found in the dozen or so cases, that there seems to be a correlation with Ang2 expression in CD163 cells. So the higher the Ang2, the more CD163 cells that were noted in the tumor microenvironment. These CD163 cells would be the cells that had the Tie2 receptors on them and would be part of the myeloid suppression. And so there was kind of a correlation between the levels of Ang2 and the myelosuppressor cells in the tumor microenvironment. Again, giving data to suggest that maybe this would be an important target to consider from both an angiogenesis standpoint and from immune regulation. So moving on to some other clinical data, working with Osama Rama in our group, who's an immunotherapist and GI oncologist, we proceeded with a phase 1b study that tested the activity of pembrolizumab anti-PD-1 with trebanumab, which is a peptibody that blocks both angiopoietin-1 and angiopoietin-2. Now, the goal here would be hopefully to get the angiopoietin-2 blockade. Blocking angiopoietin-1 would maybe potentially do a slightly different effect. But we know that both VEGF in this cartoon here, as well as Ang2, have some overlapping functions and distinct functions, both on the VEGF and Ang2 effects on myeloid suppressor cells, making important factors such as IL-10 and such, the potential role for PD-L1 on tumor-associated macrophages, and the role that angiopoietin-2 increases that expression on tumor-associated macrophages. We went back to one of the original slides showing how PD-1 on immune cells in the tumor microenvironment was predictive of atezolizumab responses in lung cancer, and other myeloid cells such as neutrophils that are becoming more highlighted in terms of their role in immune suppression. So we're going to show you the first group of patients that were enrolled in this study. Were 17 microsatellite stable patients with colorectal cancer. All had been heavily pretreated, a median time of 2.6 years since their diagnosis. In this trial, there are no DLTs, and that 30 mg per kg was determined to be the MTD for the peptibody. There were some treatment-related adverse events, abdominal distension, diarrhea, some edema, which has been shown with angiopoietin inhibitors that you get a little bit of third spacing, some LFT abnormalities, but nothing that was dose limiting. This is the dose escalation for those treated on the left with multiple different cancers, and then on the right is the colorectal cancer cohort, specifically in the first colorectal cancer cohort. So in the dose escalation, a number of cancers were treated, including colorectal cancer, ovarian, renal cell, showing that there were a couple of partial responses in colorectal cancer and some stable disease. And on the right are the spaghetti plots or spider plots, showing the clinical activity in patients with colorectal cancer who received this combination. In the colorectal cohort, the median time progression was 2.8 months, but the median overall survival of 9 months. We're going to go through a little bit of the correlatives now with this. So we applied CyTOF, which is looking at staining immune cells from the peripheral blood using antibodies that have heavy metal conjugation, which, as opposed to doing flow cytometry, permits you to do 35, 40 markers at a time. And this is looking at patients with the first 12 weeks of cycles of therapy, and specifically focusing on the colorectal cohort, and in splitting up patients who received clinical benefit as defined as either a response or stable disease lasting 6 months or more. And what we found is that there were significantly higher CD3 positive cells in patients who had clinical benefit following their first initiation of therapy. Both CD4 and CD8 cells decreased in patients that did not have clinical benefit. CD8 effector cell, specifically the memory phenotypes, decreased in patients that did not have clinical benefit. In both the CD4 and A6CR3 cells decreased in patients who had no clinical benefit, and particularly was noted in patients who had rapid progressive disease that these cells were quite low and decreased almost non-detectable. We're looking at other phenotypes in terms of an NK cell analysis. And we're going to, I think, further discuss the potential role for innate immunity here. So this is going to give you the first kind of hint of that. There were trends and increases in the CD56 dim, CD16 negative cells in patients with no clinical benefit, and that these in the CD16 positive cells were higher in patients with clinical benefit, which goes along with the potential innate aspects. There are no differences in the CD56 cells according to any cycle or clinical benefit, so it didn't seem that it was had to do with timing over treatment. And the CD56 positive cells were higher in patients with clinical benefit, as well as the NK marker P30 56 positive cells were higher in patients who received clinical benefit. This was consistent across really all the patients with statistical significance. Looking at myeloid cells, which you would assume that the peptibody might be affecting myeloid cell, that myeloid cells increased in patients with no clinical benefit. But the myeloid-derived suppressor cell phenotypes seems to increase in patients with no clinical benefit, and the classical monocytes also increase in patients with no clinical benefit. The M2-like macrophages, which the markers again are not as well defined in humans, trended to be higher in patients with no clinical benefit, but did not reach statistical significance. So the activity of anti-PD-1 plus the Ang2 peptibody, trabatinib, combination may be hindered by increase in immunosuppressive myeloid cells, leading to decrease in memory and effector T cell populations. Interestingly, there was an association between baseline NK cell activity and expansion of the cytolytic NK cells, and think that the role of checkpoint and other things on innate immunity needs to be further explored. We'll talk about that in a little bit. And we're currently in the midst of enrolling another group of 25 patients, microcyte stable colorectal cancer. That cohort is just about finished enrolling right now, and hope to get further analysis coming out. So I think in general, the role of angiogenesis in combinations is very important. It has the immune activation seen by VEGF blockade, the benefits and efficacy across multiple cancers, toxicities are manageable, but also to further consider other targets, and angiopoietin-2 being the next potential target. Serum Ang2 levels increase associated with worse outcomes. VEGF blockade may temporarily decrease Ang2 expression and affect things in the tumor microenvironment. And Ang2 could be a mechanism for resistance to checkpoint blockade that I think is deserving of further studies. So one of the questions that Harry was alluding to is how can we improve the therapeutic index? So one of the aspects is bringing back the concept of cytokines. So if you think about the original reports for CTLA-4 blockade in preclinical animals by Jim Allison, that the effect of CTLA-4 blockade wasn't really well understood or appreciated until it was combined with GM-CSF secreting tumor cell vaccines that really demonstrated the synergistic potential in preclinical animal models. And that work that Glenn Dranoff and I did together with GM-CSF secreting tumor cell vaccines with checkpoint blockade suggested a potential synergistic effect. But work by Craig Slingoff and others, and many others, have had concern that GM may induce negative regulatory aspects of the immune response by promoting myeloid suppression cells or Tregs that are antigen-specific in a number of studies that have been done. So that was kind of the concern going into this. So originally, again, going back to just things in melanoma as a proof of principle and IPI as the first proof of principle, we did this randomized study that combined IPI, noted to be here 10 mg per kg, which is higher than the approved dose, and had a maintenance portion to it with systemic GM-CSF versus IPI alone. And data has been published. Progression-free survival between the two arms was not significant, but interestingly, overall survival was significant for the GM arm, with the 1-year rate of survival for IPI alone being 52.9 versus 68.9 for the combination sargramostim or GM-CSF. We'll talk about this potential in just a moment. When we looked at side effects, usually when you combine things, you can serve over more side effects. But when we looked at the GM arm, sargramostim arm versus IPI alone, the patients in the combination had fewer high-grade adverse events compared to IPI alone. And specifically, when we looked at the toxicity types, there was a profound decrease in GI toxicity, diarrhea, colitis, and pulmonary toxicity. So colitis, diarrhea is the biggest concern for IPI itself, and pneumonitis, lung inflammation being a primary concern for anti-PD-1 based therapy. So found that these two target organs having improved benefits with the combination fairly intriguing. So what is the potential mechanism that GM improves survival but does not improve progression-free survival? So GM recruits dendritic cells, macrophages, antigen presentation. And when you combine this with counteracting immunoregulatory elements, such as with CTLA-4 blockade, you could see a synergy happening there. Maybe GM improves depletion of regulatory cells that could be that would be important when in the presence of GM. That was suggested by Alan Corman, the importance of CTLA-4 in terms of depleting regulatory cells could be amplified by GM. And this uncoupling of overall survival and progression-free survival has been previously described for other GM-CSF-based immunotherapeutic approaches. Specifically, sickle T and prostate cancer, dendritic cell vaccine has as part of its component GM put into it. And there was also a disconnection between progression-free survival and overall survival, with an improvement in overall survival in those studies that included sickle T and prostate cancer. So there's another basis for this observation in the past. But when we look at the possible mechanisms of improved pulmonary toxicities, Glenn Dranoff had done the GM knockout mouse, and those GM mice develop significant lymphoid hyperplasia that surround the airways and the lung vasculature that really clearly demonstrates the role of GM in pulmonary homeostasis. And you can see in panel A is a normal mouse lung, and then panel B being the GM knockout mice, showing the profound inflammation in the airways. In addition, GM as a cytokine is involved in mucosal homeostasis, and it really promotes GI mucosal healing. The knockout mice have colitis, and this can be partially reversed with administering systemic GM-CSF. If you look at idiopathic inflammatory bowel disease, GM may have a role there. So there are trials of giving GM to patients with Crohn's disease that have shown improvement. A subset of patients with Crohn's disease have high titer neutralizing antibodies to GM that show a mechanism why GM may be important. And some inflammatory bowel disease patients actually have decreased levels of GM receptors, again, making this combination. So we moved on to doing a randomized phase 2/3 trial of sargramostim or GM-CSF plus nivo-ipi versus nivo-ipi alone. The primary endpoints are overall survival, relapse-free survival, and potential reduction in toxicities. And as Harriet and I were talking right before this, that the trial is ongoing, is in the midst of phase 3. So I think the role of GM is interesting, possibly from an efficacy standpoint, but particularly from its possible reduction in side effects, and that cytokines may behave in different organs differently. So the lung and gut, which is a mainstay protection against invading microorganisms, GM may play a very important homeostatic role there. It may play different roles systemically throughout the other parts of the body. And this is other areas we're interested in looking at. So what drives responsive checkpoint blockade is kind of the next question. And we set up some CyTOF panels looking at patients who had received IPI alone and who received PD-1 alone and spent a long time setting these panels up. And what you find out with CyTOF is that doing the experiments may become much easier, but the analysis of the data from a computational biology standpoint can be quite onerous and such. But these are some of the Visney plots that we established looking at the different subsets of cells that we could look at in the peripheral blood. And again, focused on patients who received IPI alone initially and Pembro alone. And what we found is that patients who, between those two cohorts, lymphocytes and monocyte frequencies very much differ between responders and non-responders, where you see with patients who are responders to Pembro, there's actually less lymphocytes in the peripheral blood. Well, with IPI, that's not the case, and that there also are higher monocytes in patients responding in the blood to Pembro and than non-responders, and that is not the case with IPI. But one of the things that kind of fell out in the data set is that patients who failed to respond to anti-PD-1 had lower expression of CD69 MIB1B NK cells, so kind of activated circulating NK cells in the peripheral blood. And we've subsequently have a couple other data sets we're working on that kind of has confirmed these observations. Is it really brings out the question of what the role of innate immunity is here. We know that NK cells have PD-1 in the surface, but the most profound effects have been on these circulating activated CD69 and MIP1B positive NK cells in the peripheral blood that seems to be associated most with pembrolizumab efficacy in melanoma. So with that as a basis, we wanted to say what other aspects in the tumor microenvironment contribute to immune checkpoint resistance or efficacy. And we could have many lectures on all the areas of investigation. We've seen at ACR and ASCO recently of areas that are looking at quote unquote resistant mechanisms to PD-1 blockade. So we talked the importance of having CD8 infiltrate, the importance of interferon in the tumor microenvironment, and then things such as beta-2 mutations that may be part of the APC machinery, or JAK mutations, part of interferon signaling, that may be important resistant mechanisms. But we were further interested in looking into that. My work with Scott Rodick was specifically wanted to look at the protein level of what class 1 and class 2 as part of the APC mechanisms are doing as part of this resistance in relative to checkpoint blockade. So we took advantage of this study, the so-called Checkmate 064 study, investigation study, that randomized patients, untreated patients with melanoma, to either receive first Nivo induction, followed by a forced switch to IPI induction, or the other half of patients received IPI first induction for 12 weeks, followed by Nivo. And then after both induction periods, all the patients got Nivo maintenance. And everyone got biopsies beforehand, in between the two inductions, and following induction 2, as well as a collection of peripheral blood samples. And we wanted to look specifically at the protein level. So this is work on panel A by Scott Rodick in looking at class 1 expression in the left-hand column and class 2 expression in the right-hand column. And there's a little bit of art to this. So if you look in a Roman numeral 1, 3, and 5, you have high levels of class 1 expression, which you should see in all nucleated cells, right? All nucleated cells should have high class 1 expression. 3 is decrease, and 5 is almost absence of class 1. But interestingly, in this tumor, you have your control cells there. You have immune cells there that have class 1 that kind of show you, I think, fairly profoundly that the tumor itself has lost class 1. And then on the right-hand column for 2, 4, and 6, you have class 2 expression. You have high class 2 expression, which is typically not all that common in cancer and melanoma. You have medium, and then you have kind of no class 2 expression in panel 6. On the bottom figure, what we've done is we've color-coded on the top the level of class 1 expression across all the tumors that were evaluated. So the darker has the highest class 1 expression at protein level, all the way down to kind of complete loss of class 1 expression on the right. And then right below that is, by IHC, is class 2 expression. And then we looked at both RNA-seq and whole exome sequencing for these samples. And so the middle panel shows you by RNA-seq class 1 expression, HLA, A, B, and C. And on the bottom shows you where there are mutations and the things that you would be most interested in, such as beta-2 and JAK-STAT. So of note, there were very few mutations in beta-2 or JAK-STAT. And actually one of the beta-2 mutations, if you look on the left-hand portion in purple, where there was a detected beta-2 mutation, actually had very high level of class 1 expression by IHC. And when we look into there, that actually patient's tumor was estimated to have about 7% of reads had a beta-2 mutation. So most of them did not, but it was probably a minor population and maybe suggest mechanisms of acquired resistance going down the road. So we looked at the initial response to patients who either on the top here received IPI first, or so CTLA-4 blockade, or on the bottom received Nivo or anti-PD-1. And what we found is that the patients who had reduction in class 1, which was determined to be 50% or more reduction in class 1, did really poorly to CTLA-4 blockade, to IPI, while patients who had reduction in class 1 did not seem to affect the response rates or outcomes to Nivo. Interestingly, patients who had any class 2 expression, as defined by 1%, did really well to Nivo, had an improvement in outcome to Nivo, but did not seem to affect at all their clinical outcomes to CTLA-4 blockade with IPI. So these are the Kaplan analysis, and so the gray are some patients who are not evaluable, a few patients. And here we have the blue being patients who had intact class 1, so greater than 50% or intact class 1, and the red being patients who had a reduction of 50% or loss of class 1. The patients who received IPI first and went to Nivo, you can see here, did much better. Who, if they had class 1 intact, if they had reduction in class 1, they did very poorly in red. And it actually took us a little while to figure this out, because there were a number of patients who received IPI first who were quote unquote not evaluable at first. And the reason is because some of those patients who had the lowest class 1 expression or complete loss of class 1 expression, unfortunately never made it to the first set of staging scans. They either progressed very rapidly or passed away early on in their treatment course. This is compared to on the panel on the right, who received Nivo first, and there was no difference on their class 1 expression on outcomes to Nivo. Here's class 2 expression. Again, on the left, patients receiving IPI first, on the right, patients receiving Nivo first. There was a slight trend, but not some difference for IPI first. But the patients who had any class 2 expression did really well to Nivo, as depicted by the blue line on the right-hand panel. So we had the RNA-seq data, and we wanted to further kind of investigate what genes could be related, with a focus on the patients who received Nivo first. And these are the top genes that were associated with good outcomes, but had low class 1 expressions. And many of these are interferon target genes, as you can see, as you would expect. And of note, down near the bottom is IL-15, which would be a target for NK cells that was also significant in that. So we looked at the interferon genes that were associated with outcomes in the patients who received Nivo first. We also had the interferon published gene signature from Merck, and Tony Rebus they looked at Pembro. We had our top 25 genes, and of course, any good computational group would want to have their own signature, so they developed their own interferon-related genes, had some overlap. So on the left are patients who received Nivo first, on the right are patients who received IPI first, and the patients who had these signatures and had low class 1 expression still did very well to Nivo, but the expression of these genes, most of them interferon target genes, did not affect their outcomes to IPI. And so this is what you would have expected. When we looked at the patients who received Nivo first and had low class 1 expression and looked at what other gene signatures were associated with that, the patients, again, who got Nivo first, there were some gamma delta cells that were associated with good outcomes, as well as an NK signature, as depicted on the left. And those signatures were not influential for patients who received IPI first in terms of outcomes. We were able to, in those patients who had low class 1 expression and good outcomes, were able to identify in the tumor microenvironment by IHC both gamma delta and NK cells. There were few, but they were detectable in those patients by IHC. And as kind of hinted to before, IL-15 specifically in the patients who had low class 1 expression received Nivo first was associated with better outcomes on the left here, and we're not influencing the outcomes to patients who received IPI first on the right. So we were interested in trying to confirm in some way another group of samples that were well clinically annotated for outcomes, and went to the Checkmate 069 study, which was a study that had got the approval for Nivo IPI in melanoma. And so there was one group of patients that received nivo-ipi and another group that received ipi alone and had samples available for analysis. What we were able to show is that the patients who got ipi alone, who had downregulation of class 1, basically had 100% negative predictive value for both response and for poor clinical outcomes. So if they had loss of class 1, again, they did very, very poorly. For the patients who received nivo plus ipi, there were trends, but there was nothing significant. Obviously, this is not ideal. It was a combination that it was hard to dissect out. There was a trend towards maybe class 2 being beneficial, but it did not reach statistical significance. Here are the Kaplan-Meier analysis for patients with class 1 expression. Again, high versus low class 1 expression with ipi on the left and nivo plus ipi on the right. And you can see the difference for patients who received ipi with low class 1 expression doing very poorly. There was no difference for patients who received nivo plus ipi. And here's class 2 expression that again reached, had a trend, but did not reach statistical significance. So it appears that CTLA-4 blockade responses are dependent on MHC class 1 expression, while PD-1 blockade is not entirely dependent on class 1, but is improved with class 2 expression and with also previously described interferon signatures that really show the importance of interferon there. I think this raises a lot of questions on what other aspects interested do. We're interested in looking at other cancers, and the class 2 component, which has been also reported by other groups, importantly, suggests that maybe CD4 cells making gamma interferon could be very important for PD-1 blockade. The dependence on class 1 for CTLA-4, we've always been interested in using this as a predictive biomarker prognostic studies, and are looking at other groups of patients, both nivo plus ipi, in order to try to really say if patient has downregulation of class 1, should ipi be considered or not as part of that regimen. So we're really now applying newer technologies to understand the spatial relationships of the immune cells to the microenvironment, doing both MIBI and other important imaging techniques, CISIF and others, to understand the interactions of these immune cells, myeloid cells, CD4, CD8s, other aspects, as well as the APC machinery, nearest neighbors, to understand the interaction of the tumor microenvironment. We think it's important to better define the role of class 2 and CD4 cells, as well as the potential role for innate immunity. We have some hints there, both from the early CyTOF, as well as some of the aspects in looking at the difference between nivo versus ipi or CTLA-4 versus PD-1, the potential role for NK cells, even with checkpoint blockade. Important role of cytokines, both the efficacy as well as some examples of possible reduction in toxicities, the combination of angiogenic factors, and really using data for rational combinations of checkpoint blockade-based therapies in the future. So many of the things I've discussed with you today were investigator-initiated, and it's always very hard to do investigator studies. And this is just a list of the many folks that were involved with these studies and the correlatives that result from them. And I just want to pay thanks to them. And these are my disclosures too. Thank you.
Okay, thank you, Steve. I'm going to ask folks to please enter questions into the chat box, but while folks do that, I will start with one or two, if that's okay with you.
Sure.
So first question, was the dose delivery better when you gave the IPI and the GM-CSF versus IPI alone? In other words, were you able to get more cycles in?
No, that's a very good question. So when when we looked at that in response to some of the reviewers' comments, that was a good question, there did not seem to be a significant difference in number of cycles that were between the two arms. So yeah, that's a great question. So if you reduce we know that CTLA-4 blockade, we know that IPI is dose dependent, right? We know going from 3 to 10, you have more toxicity, you have more responses. And so the question, a great question, is whether you could just get more drug in. And there did not seem, at least between those two arms, do not seem to be a significant difference between that. But that's a great question, something we need to continue to look into as we move on to the nivo-ipi study.
No, thank you. Next question is, so what directions are you planning on taking for class 1 deficient melanomas?
Yeah, number one, have been interested in looking at whether the class 1 observation is important in other cancers. So Nivo-IPI is now lung cancer and kidney cancer, and we've been trying to gain access to some of the same just to see, does class 1 influence that? So that's the first thing. The other thing is we were kind of interested to look at just even a biomarker driven trial for class 1 expression to say, should patients who have low class 1 expression be getting IPI, or if there's an efficacy change. We just haven't been able to get traction to do such a trial from a logistical standpoint.
Yeah, it's very complicated, and you got a lot of them going on. So there's a question from the audience from Antonio Moro. Thank you for your presentation. By the way, thank you for the presentation. It was awesome. I was going to end up with that. In the GBM trial comparing Nivo versus Bev, patients with PD-L1 expression survived longer if they received Bev. Do you have any ideas as to why that could be?
Yeah, so one of the questions that's confusing is whether the PD-L1 expression is on the tumor or on the myeloid component. So in brain tumors, you're going to have the myeloid-like cells around them that probably have a lot of PD-L1 expression. And so one of the hints from the Genentech trial is that the immune cells that express PD-L1, the myeloid cells also were both markers for predictiveness to improved outcomes to VEGF blockade. And so depending upon, some tumors may be more myeloid dependent or more myeloid rich than others, and could, by blocking VEGF or angiogenic factors, you actually having a greater effect on that myeloid suppressor compartment, the myeloid suppressor effect, than actually on the tumor itself. So I would mean, without having a definitive answer, that would be one of the hypotheses, is that when you're blocking with Bev, that you may be affecting both your immune cells that are PD-1 positive, as well as the myeloid component that affects. And so if the tumor is more dependent on myeloid cells and such, that myeloid suppressive cells, you may be having a benefit by blocking VEGF there. That's, again, something that needs to be more definitively determined in patients, but I think a reasonable hypothesis.
Now, then maybe Antonio can respond to the question of whether it's actually primarily expressed in the myeloid cells or in the glioma cells themselves, because I've seen some really strongly positive gliomas, tumor cells.
Yeah.
But it's interesting. Then while folks enter other questions, I'm going to ask you a question about your early data on the vasculopathy with the CTLA-4. That figure that you showed was actually quite stunning. Do you think that that's organ dependent? You're more likely to see it in the liver or whatever organ you think, maybe you haven't had a chance to look at that.
No, so we've so at least in that very early study way back when, it did not seem to be organ dependent. We saw the vasculopathy in many different organs that were biopsied, and so we've also, as many are, looking at tertiary lymphoid structures that anti-angiogenics may also be influenced in. So we actually saw a large, I didn't get into this in too much detail, a number of tertiary lymphoid structures associated with that. And we think that maybe those are making antibodies and those are associated with good outcomes. But as we're looking for these tertiary lymphoid structures, we also saw these vasculopathies in many different organs. So there's different degrees of it, but it does not seem to be organ dependent.
Mm-hmm. Interesting. And then if you followed up on your studies of the Ang2 expression and the titers in patients who got IPI-Nivo, those blood studies that you showed. Yeah, showed IPI.
Yeah. So with Nivo-IPI also, we do have some data that we're putting together that while the antibody titers are not as the increase in antibody titers are not as high if the patients hadn't received Bev, which maybe again suggests maybe there's some human immunity effects to anti-VEGF. Patients who did develop antibodies to angiopoietin-2 with Nivo-IPI did seem to do better than patients who did not. But we're waiting to do a confirmatory cohort right now.
Mm-hmm. That's great. So you're planning on following up on those studies with the angiopoietin 1 and 2 inhibitors in other cancers, or with IPI-Nivo as opposed to other drugs?
Yeah. So Harry, you're always my therapist. It's always been challenging to gain access to these drugs for clinical grade to do some of the studies you'd want to. So that's been one of the challenges. But there are some companies that are looking at dual VEGF Ang2 inhibition in cancer, and I think that those studies will probably be able to shed further light. So when you block VEGF, Ang2 goes down temporarily, and then Ang2 comes up as kind of a resistant mechanism. And so the question is whether blocking Ang2 would also be beneficial with VEGF. In likelihood, it probably would be in terms of if these hypotheses are right, would affect PFS because you'd be blocking Ang2 once resistance comes out. So some of those trials are being done. The early on Ang2 inhibitors that were studied were many of the companies have shelved that as a target because the Ang2 inhibitors, when combined with chemo, didn't seem to do any better than blocking VEGF combining with chemo. And so there was, I think, less enthusiasm at that point. Hopefully some of the mechanism questions and the questions in combining with checkpoint blockade may give a little bit of impetus to look at this further in cancer therapeutics by combining with checkpoint and the complexities of androgenous factors. So hopefully there'll be some reinitiation of that.
So what happens to angiopoietin-2 levels when you give a VEGF receptor inhibitor as opposed to anti-VEGF, especially the dirty inhibitors?
Yeah, I don't think I haven't seen any data that specifically looked at that.
Mm-hmm.
Yeah.
Not your disease.
But I think, yeah. So I think that the kidney cancer and all those studies could look at the Ang2 levels. I have not been able to look at that, but that's a very good question. I mean, even the lenvatinib studies that have been coming out in melanoma and others are also very interesting. Lenvatinib will hit VEGF receptors, also FGF, and those studies, some of them just recently presented at ASCO, are also kind of indicative of this combination. So then looking at its effects on other androgenic factors, Ang2, I think would be an opportunity.
Mm-hmm. Mm-hmm. So Steve, as a final question for you, what do you think the next big hit is going to be in melanoma? Let's put aside the LAG-3 because we already know about that one.
I think that the lenvatinib data also looks very interesting, right? In terms of combinations, where that fits into the portfolio of options for patients in terms of line and such, will need to be kind of further detailed. I do think that as a field for immunotherapy in general, making hints to it that we have to understand the role of innate immunity in that. So some of the targets for NK cells and targeting myeloid cells, I think, are interesting. They're very early in development, but melanoma and other cancers who have PD-1 as a base will be an opportunity to test those aspects. With innate immunity, it's not a matter of just getting the innate immunity started, but I think more of how durable that those immune reactions are. So NK cells may be interesting, but how do you propagate them long term? So I would say, the LAG-3 looks good. I'll say angiogenesis looks good. We'll see what GM does, but that the future interest in other excitement, in addition to the checkpoints, would probably be how we manipulate innate immunity to help patients with cancer in the future.
Steve, I think there are no other questions